think we recognize in value-based care. You know, I have a background as a family nurse practitioner. I'm not a physician. You know, I'm not a chief strategy officer. But for us, there's a recognized shift in age and acuity in our senior living residents. And I love, Jim, if tee you up a little bit of discussion of how you've seen that shift and evolution of the residents that we're serving in these communities. And what are your thoughts around that shift and how it affects not only primary care and how we deliver it, but through the lens of value-based care?
Yeah, so this kind of won't surprise most in the room who are far expert than I am, but I began my career in this space back in 2007. I went to work for a company called Evercare, which was delivering risk-based health plans and primary care and a clinical model to nursing homes predominantly. And you know, those were the same type of residents that in many ways I'm seeing today in seniors housing. I was privileged to, in 2010, go and join a company called CareMore Health, where I spent 11 years building out similar solutions where we were bringing the healthcare and the health plan to residents of senior living settings. So moved from the SNF space to more predominantly the assisted living space. And again, I think throughout those two experiences, and even now my time at Pine Park, I'm seeing what I think you all are, which is the residents in these communities are older, they are more frail, they are desperately clinging on to what levels of independence they still have. They are trying their damnedest not to move from the IL side of the house to the AL side, or God forbid, the memory care side. And then to talk some insurance kind of jargon for a second, what that means in practice is their risk scores are higher. And for companies like ours, that doesn't necessarily mean a bad thing if you're documenting and coding them correctly. It could mean the right revenue that you're bringing in the door to care for them, but it means their risk profile is quite high. It means that if not cared in that way that Coach described earlier of proactive, preventive, access-based, these folks have a high likelihood of one, if not more, hospitalizations while they're under our watch. It means that ultimately it takes companies and physicians and teams to really jump in and make sure that we're slowing that slope of progression, allowing them to live longer, healthier, happier lives and truly age in place in the communities that you all operate. And if we don't, we see what we've seen over the industry, which is many operators I partner with have seen their length of stay slip. They're moving residents in sicker, they're moving them out sicker, and that time in which we get to interact with them and their loved ones is kind of condensed and consolidated. So that's kind of in a nutshell what I've seen over the past 15 or so years in the space.
Perfect, thanks, Jim. Dr. Morehouse, is this, you know, does it resonate? Like, what do you see from the physician lens, you know, being a chief medical officer for Edgewood, you know, and just how does it look? Is it truly that they're just getting older? Are they not wanting to be sick? None of us want to be sick. Like, what are you seeing in practice that is really differentiating senior living? Like, what is unique about this population and that they're not only older, but also more frail?
Yeah, so my experience with this is I started off in the skilled side of it. And what I noticed over the years is the hospitals were kicking out patients faster and faster. And it turned into the med-surg floor, basically. I felt like these residents need to be seen every day. And then as a physician, you're like, well, is that Medicare fraud that I'm seeing someone so often? Because that's what we're held to in that standard. And it's just morphed down and trickled down into the assisted livings. You're getting higher acuity, more problems, but yet the staffing in an AL is nothing like the staffing in a skilled. And what is the responsibility in the AL? And it's really put a lot of pressure on, and that's really what's changed how Edgewood looked at it. 7 years ago, they changed from an assisted living company to a healthcare company, and we incorporated primary care within all of our facilities. And we've seen the difference. As Coach was saying some of those things, we've watched that morph over time within our own system.
So you're saying you're getting sicker patients, which means you get more support staff, right? In the community? No, right?
You don't.
You don't.
You don't even have a nurse all the time.
Exactly.
And so how do you deal with that? And how do families deal with it? They say, send mom to the ER.
Mm-hmm. That's the easy button, isn't it?
And then I used to work in the ER a long time ago. In the ER, I got an 85-year-old that is sick, what do you want me to do? That's the question. Where do you want me to put them? I can start an IV. I can put them in the ICU with urosepsis, which that's the diagnosis we hear all the time. And we just ran a $60,000 bill when we could have just gave them an IV in their home and prevented the whole thing.
So Dr. Wahab, working with those pressures and seeing this opportunity to care for more complex seniors in their home, how do you approach that? You know, with Curana Health in your own practice and your 25 years of experience, how does that look for you?
So what I believe is that we really have to be, as a provider, engaged in the building. You really have to become part of the culture. You know, that's the only way that you can really get to know the residents, get to know the building, how it's operating, and improving the care. So more frequent touches, more frequent contact. You know, the building should not be scared to call their provider to ask a question. You know, so when I'm sitting at the nurse's station and they're drinking, I got to call this doctor and tell them this patient needs a med change or they're not feeling good. I know they're going to yell at me. You know, that's not the case. We have to be part of the culture of the building. They've got to be comfortable with us. From the nurses to the CNAs to the director of nursing to the ED, we really have to be in there and show that we want to improve the care of the building.
So how, you know, let's kind of continue on that thread there. You know, thinking about not only are we recognizing the increased acuity and age of our seniors in the space, how has your practice and as a part of Curana, right, evolved in that time? Like a kind of a storytelling. I think that's a great opportunity for us collectively in this audience to really hear from two physician leaders, you know, in the space. How has it evolved in your practice? You know, you mentioned good communication. That's probably always been a part. How do we improve and take it to the next level to really succeed in value-based care?
So when I was first in post-acute full-time, you know, I went, when I was in Chicago, I was a SNFist, going to supported living, assisted living buildings. And the mindset was, see as many as you can because that's how you get paid. Because
that's fee for service, right?
Exactly.
Okay.
Exactly. So you know, being the middle child, I'm always wanting to prove myself. So I was working as hard as I can. I was the highest producer in my group. You know.
How many years?
I was
joking. I know you can.
So I was working really hard. I think one of the seminal moments of what I've got to make a change. You know, it was Friday, 4:30. I was hitting my third building, trying to get everybody tucked in before I go home to my family, and it was in the hospital as usual, emptied their floors as much as they could, expecting admissions. So I had 5 admissions I had to do at 4:30, and the EMR was basically just a word processor, and I knew I'd be there till 8:30, and missed my family. My children would be asleep, and I said there has to be a better way. There absolutely has to be a better way to practice medicine in this space and still be successful. So. Eventually, I was a medical director of a CCRC, which I loved, which has really helped me with continuity of care and helping these people go from IL to AL to long-term care. But still I wasn't able to really make that big of an effect. I really wanted to see a change with medicine. So then one day I got a call from an owner of some SNFs. And he said he wanted me to start the medical care in an IE SNP model, which I knew nothing about. So I looked that up and I said, yeah, this is exactly what I've been wanting to do. So we pushed hard with that. We're successful, no longer looking at how many patients I saw, but more the quality that I gave. You know, we looked at quality metrics. And my team was doing great. And also, more importantly, we looked at the time that the residents were in the hospital, in the facility. And my group, compared to fee-for-service providers in the same building, our residents were in there 37% longer than the fee-for-service folks. So we proved that we provided better care and also kept them healthier by keeping them in the building.
Wonderful. No, that's amazing. You see the impact in the data, the numbers, and how it's represented. You know, as a family nurse practitioner myself, it's about how can you manage a population and not worry about the fee-for-service mentality. I need to get compensation for seeing you. How do you engage and interact with the residents in order to actually really be a good steward of their health care? You know, Dr. Morales, how do you do this in a lens of, you know, through you and your perspective on really engaging these seniors to have these health outcomes, to have this increased length of stay, because I think in senior living is really unique. There's a wonderful synergy when it comes to increased length of stay. It means we're driving down healthcare costs, meaning our residents are staying healthier, happier in their home, because every time they go to that hospital, their morbidity and mortality goes up. So it's a kind of a perfect triangle. In your perspective, does that resonate with you? How has your practice evolved in primary care in your space?
So coming into the assisted living says it's been a challenge because of regulation. Each state even has different regulations. The coach talked about having so many physicians in a facility, so it's disjointed. So with Edgewood, we decided that we would go a model of having a medical director, which is not required in assisted livings. But we went ahead and went with it, and that way it was more consistent, that we can get the consistency within the residents. If their physician is not taking care of that patient, we can step in and help out. And we've actually won over our residents by being there and being exposed. And also, when you have a nurse that's struggling with all those residents, and you got one nurse in a building, and she knows she can come to the provider that easy, it simplifies the whole process. And then everybody becomes a team and supports each other. And that's how we've been able to prove that length of stay. We have data, just like he's talking about. When I was in the skilled, they'd measure us on the hospital bounce backs for years. And I'm going to toot my horn here a little bit, is my bounce back rate in all my facilities, I had 12 at one time there in Boise, was less than 6%.
That's amazing.
And the national average is around 14%. And even of that 6%, patients have rights. If they want to go, they can go. You can't stop them. But we've developed a relationship with our residents that they have a trust in you that, hey, we can take care of you here. You don't need to go to the hospital. And if you get to know these residents, they really don't want to go to the hospital. They know that they're not offering them much more than what we can do here.
Jim, with Pine Park, just how do you look at it? Hearing both physicians speak, what resonates with you, and what are their thoughts on how you approach, solving this opportunity, right? Providing solutions for it.
Yeah, the few things that come to mind are, and I think that we're going to experience this over the next day and a half. Value-based care is not a linear journey. It's not a light switch. And a value-based care company alone isn't going to, as a single source solution, prop up all these outcomes. I don't know very many Medicare Advantage plans that just by contracting with CMS and convening an adequate network are successful, right? Usually you need a physician, both to impanel patients or in the case of an ACO, attribute beneficiaries. You need a physician as sort of the linchpin to that success. They're that engagement vehicle. They're the ones walking into your community. And so I think that the physician role is incredibly pivotal to the success of value-based care on your campuses and also outside of the walls. I think the other thing that should be captured in that is that, these physicians, they're interacting with your residents at a critically important time of these residents' life. And so to go through that fragmentation of the 30 physicians in one single community is incredibly disruptive to your operation, to the residents' life. Most of the residents that our company picks up and begins serving, when look no further than the MAR to see how many doctors are involved in their care. And when you see that this one patient, this poor patient as an example, the average might have 12 what are called Part D scripts on their MAR written by 6 different physicians. And it's where did we go wrong? Yeah. And you look and you trace back to where those physicians interacted with a patient, and this patient's taking, say a hypertension drug that they got from the ER on this visit, and they're taking a diabetic drug that they got from a hospitalization here, and a COPD inhaler they got from a sniff visit there. And so all those things, it's important that you have that linchpin of the physician role to unwind that and to talk with the patients and the families and your community staff and drill into what does that patient care about? Where are they at in their lifespan? And what can we do as a unit to make them feel happier, healthier, better for whatever time they have left? And what will usually happen when you sort of get down to those basics is you are, in a sense, being able to sort of free them from the unfortunate system that's kind of put them in that tailspin. They want that, they need that. As Coach said, this isn't a let's get rid of their choices. This is we're coming across these residents at a super important time of their life. And I think we owe it to them. We have a responsibility to them to help unwind the fragmented care they've experienced thus far. And a physician can do just that and can enrich the lives of your community staff, which is another huge reason to sort of seek out value-based partners in this space in your communities. And by the way, there's lots of them. I mean, I don't know if we wanted to do another poll, what would be interesting to kind of pull the groups in the audience and become more aware of is, did you know that value-based care in many of your communities already exists? You just don't know it exists. There's physicians coming into your community that are part of ACOs. There's health plans sending patients to your building from a post-acute stay that are, in essence, at risk. There's health systems now that have either Pioneer or next-gen ACOs, or even now, other types of ACOs, and they're sending patients. So VBC is live and well in your buildings. It's just somebody needs to take the reins of it now, and somebody needs to start being intentional with it.
No, it's great. I think you're absolutely right. It's just so prevalent and not always at the surface, right? And how, as we've got a room full of operators and medical groups, sometimes the operators don't get the choice to actually participate in those value-based care and aren't aware, right? So they're even getting people dictating or groups dictating what they should do and how they should perform. But you mentioned, just continuing on the theme of what the role of primary care and value-based care is. The analogy that sticks with me, and what position would you say that the primary care physician group plays on the football team?
Well, I think, why don't I pass it to the physician?
There you go. There you go.
As opposed to the one that took the MCATs twice and is sitting up here on the business side.
I would say quarterback. I say we really everything falls on the primary care doc. Whether good or bad, it's always the provider that's in the building that has to run the show from that clinical standpoint. So we really have to be strong, and we have to know what our goals are. Where do we want to take the practice? Where do we want to take the building as far as quality of care and time in? So, and you've got to choose a primary care provider that really wants to be there. I don't believe that care in this space is no longer the side hustle job. When I started, I was the triple threat doctor, right? I was rounding in 2 hospitals. I had a primary care practice, and I was medical director of 2 long-term care facilities, and that's what I did for 10, 12 years. And now I just don't think it just doesn't make sense. You can't get to the level you need to be in this space by having any other distractions. It's just a full-time job.
Yeah, I agree with the quarterback. I mean, we've always said that the providers, the physicians, have the power of the pen, right? They're the one able to facilitate care by writing orders. And, I think the connective tissue in which the responsibilities of a quarterback on a football team are so important, right? They've got to be the leader in the huddle, on the field. They've got to distribute the ball, right? They've got to, let the linemen whether they're doing right or wrong, but they're no more important than every other piece on it, right? They have a role, they're important, but they're not necessarily the most important piece. Because without a solid left tackle, our offensive line, you can ask Texas here, who've suffered the last several years, and we're on a rebuild, we're doing good. We're going to beat Georgia coming up this fall, but we need an offensive line to protect us. And so we needed the Andy Ebes of the world to protect us and make sure that we've got cover. But really, moving away from the sports back to an important topic, partnerships. What does that look like, right? What does a good primary care partnership look like? What does a bad one look like? Any thoughts there? I mean, you've had a strategy of in-house. There's a question on the paper that we're going to talk about. But what's the strategy there?
Yeah, I think we just talked about it. The quarterback, is not necessarily the most athletic guy on the team, right?
Tom Brady.
He can't run.
He can't run at all. So bad.
But you got to have someone who comes in as a physician. You can get the hospital system to come in. They're going to dictate how they want it, and it doesn't work for us. It just doesn't. And I think a lot of companies are afraid they don't want to disrupt that relationship with the hospitals. But the truth is, the hospital doesn't care what you do. And I think it's very important to have medical leadership in the building that also understands the assisted living side and their struggles and challenges. You know, a lot of the buildings that I go into, it's all about the survey. And we need to get away from that. We got to go right back to taking care of the patients. That'll win it. But I can't tell you how many buildings it's all about the survey and, oh, we only got 7 tags this time, let's just take it. You know, and that's a loss for me. As a physician, you're like, wait a minute, I don't want to tag at all. But you need to have people who understand the other side of it, and so you can work together. It's not a one-sided thing. And oftentimes, as clinicians, we come in and say, just do this, and it doesn't work that way. You really have to have an understanding. But once you win that over and have that trust, there's a lot more power for us as the physicians to help those buildings.
Makes sense. Jim, any thoughts on good partnerships, bad partnerships?
Just a couple, and maybe totally agree, by the way. I think something I've become more appreciative of as I've spent more time in the space is you should be working with primary care groups that are also fun. You know, this work is hard, and there's a reason that not a lot of groups are successful in doing it or running towards it. And so those that are, you know, you should be welcoming in primary care practices that will take the time, like I've spent with Dr. Wahab and watched him do, that will sit with your staff and educate them on a case review or data. Like, have you ever polled your X number of primary care groups in your building, like, hey doc, you know, what is your 30-day all-cause return to acute? What is your admissions per 1,000? How many scripts are you writing per member per month? And have you ever seen them come to you with, sports analogy coming, like their playbook and their game film, which is a claims history of the care that they're delivering for residents in your community? So I think fun, engaging, data-driven come to mind for the physician practices that are really going to be successful in this next wave. Also, clinicians that know how to embrace the network that you've convened. You know, not just amongst the sponsors that we saw on the banner here, which, again, thank you all for what is already an incredible venue and an incredible conference, but I've worked with physician practices where it's, oh, this patient needs a specialist, I'm going to write this order and send them off. Well, A, is that specialist even in network with the patient's health plan? Mm-hmm. B, have you already asked the community if they have on-site specialists that they're bringing in for the same service? Because, you know, why jump over a network that's already working well within the building? C, have we even talked to the patient and family about informed consent, and do they want to seek curative treatments for this, that, and the other disease? So thinking about working with physicians that know, hey, before we launch care together with your community, who's your preferred audiologist? Do you have a dentist that comes in? Who's your preferred home health agency and hospice? Like, let's really unify the care delivery in this community as opposed to further disrupt it and fragment it and make things harder on ourselves and thus your residents.
Yeah, it just resonates so well with me. It's almost like, you know, someone that has a playbook, but also a company and a partner that actually can make second half adjustments, right? Because, you know, we can have a playbook and you're saying, hey, this is what we do. But we know every community within a portfolio or ownership group is unique. They have strengths and weaknesses. And how do we apply 85% of what we do and that 15% customization? And how are we, you know, national companies like ours, how are we really tailoring it to the unique market or region or community in which they serve? I think it's so important. And another thread to pick on is, like, we always talk about choice. Coach talked about choice. Patient choice is there. But in healthcare, it's a unique space in where it's not informed choice. There's not a lot of data around it. It's like, hey, here's a list, here's a phone book, let me just throw it at you. It needs to be informed choice, the right partners. Who do you like? Okay, you don't have someone, here's the best in class, a couple other options. How do we create networks and partnerships that really serve us for the best outcomes and making sure they're aligned? Dr. Wahab, any thoughts on, like, how you utilize specialty services or partnerships, you know, outside of primary care in senior living, thinking about value-based care?
Right. So I'm very, you know, since I've been doing this for a while, I've kind of vetted who I work with, and whenever I go to a building, I say, okay, who's your therapy group? who's your psych services, who's your DME group, who's your wheelchair rep, that kind of thing. And if they're happy with who they work with, I'm happy to use them. But if not, I'm bringing in my team, because I know that I've worked with them for the last 8 or 9 years. I know if I call my wheelchair rep, he'll bring out a loaner chair until he gets fitted for the real chair for 2 weeks down the road. I know my therapist, if I can call them up, I've got an emergency, it's Friday, I've got a patient that's acting up. I don't want to send them out to a hospital where they'll come back, late Friday night, and then we'll have to deal with it Saturday and Sunday, and therapy. The therapy group, work with Fox, love them. I've got the therapist's phone number. She has mine, and as well as the nurse practitioners. Any concern, call them up. We get things taken care of, and we straighten things out. So you really have to have a good team around you that you can rely on to take care of the residents.
Dr. Morales, just continuing, I really want to lean in on the value-based care and what's different with primary care and how it's practiced through the lens of value-based care. We talk a lot of the things that are, they work well in fee-for-service. What's different about primary care's application and its importance and with these specialty partners? Is there anything unique, or is it just, hey, we're taking great care of these residents? It needs to be communication, the right partners, and have access to value-based care opportunities that are putting the carrots out there and incentivizing good behavior?
Yeah, there is reluctance and hesitancy from physicians with value-based care. And I'm just going to give you an example. In my own practice, if I have 100 patients that are age 45 or older, and 50 of them get their screening colonoscopies and 50 don't, I get penalized for that. So as a physician, you get really wait a minute, that's not my choice. I've already talked to the patient. Patient doesn't want to do it. Mm-hmm. But that's how this is coming about. And I don't know how to fight that other than become a part of it and continue to drive it home to my patients the importance of it and win them over so they'll do it. And I think that's what Medicare is actually looking at, that we do have that kind of influence to get our patients and residents to do things because it is more cost effective, it's better outcomes, and prove it. But there is a lot of reluctance on patients. They have their rights. But a lot of times people refuse things because they really don't understand why we're doing things. Mm-hmm. And as a clinician, we're not very good at communicating sometimes. If you go see a specialist, they say something and then they come back to me, my residents come back to me and said, well, this is what they said, I don't know what that means. And so it's the time you talked about, the speed fee for service. Doesn't allow you that, but in the value-based side, we can spend a little more time and develop that relationship, and then they trust you more on getting these things done so we can prove those outcomes. And the same thing with the specialties. When I refer someone to someone, I'm referring to someone that I would send my own mother to, mm-hmm. my own child to, because of that trust and relationship, and you know that it's going to be done right. And also, I have a little control in that. I can call and say, hey, I need this done. And speed is critical in all of this. That's what stops ER visits, right? A nurse calls and they can spend 2 days trying to get an order from the physician in the community, or they can call you, you answer your phone and you say, hey, just do this.
So I hear a couple things. The why, I think explaining the why, not only to the residents, but our partners, the associates, the people you're referring to, is so important for them to understand. And then also, you both, as physicians and parts of large medical practices, and Jim leading as well, I think having incentives that encourage good behavior, right? That give you competence and give you skin in the game through value-based care, I think is extremely important. Any thoughts on that, just having skin in the game, Jim, on just why primary care and value-based care and these operating partners, why having skin in the game is so important?
From the lens of the physician?
Sure.
Well, I think it kind of goes back to a few of Coach's slides, which is we need to fundamentally shift, especially the healthcare for our older adults, to being more outcome driven. And if you're working in a practice where you're getting effective reimbursement or shared savings or bonusing or a percentage of your margin based on the outcomes of your residents, it allows you to then reinvest those hopeful profits back into the practice. It allows the practice to invest in care coordination and maybe offload that from your communities. It allows the practice to invest in pharmacists and maybe offload that from your building. So I think it's just an appropriate way for practices to bring in the right types of revenue, the right based on the avoidable waste in the setting, and then reinvest that in a very altruistic way back in their practice, which ultimately comes back to the patient.
Perfect. I think we're going to hit time perfectly for our part of this. We're really excited. Is there someone coming out? But just hopefully, this great discussion. I just want to thank each of y'all for your contributions and trying to help us explain the importance of primary care through value-based care lens. Oh, here's Coach. How'd we do, Coach?
Man, look at that. 0, 0, 0. Right on time.
You like that?
Man. Thanks. Way to go, guys. So, what's next is we'll hear from you, right? So, this is a breakout. So, what we want to do during the breakouts is if you turn to page 17, we've got 3 questions there that we want you to talk about at your table. And then we're going to come back. We're all going to come back on stage. We're going to have a little breakout integration. Then we're going to talk about what was discussed, what you heard, what caught your attention, what was of interest, and do a little breakout integration, all right? All right, we had some really good discussions going on, so now we just want to talk a little bit about like what we heard and what some of the interesting thoughts and discussions that were taking place. So again, we got 15 minutes, the clock started, so anybody hear anything that really kind of grabbed or captured their attention? Michael, looks like you may have something.
Yeah, just kind of overhearing a table talking about, a primary care solution partner that is truly payer agnostic. Coming in and someone, not only having a strategy on what they can bring to the table, but really delivering it for all residents and not just a subsect of it. Because when they're not available to service all residents in some capacity, you run into that same problem of, well, I'm only serving part and you have to bring in another, and that fractionalization of that opportunity. And so having a partner that is payer agnostic, willing to service all your residents in some capacity was really key.
Yeah, and we've seen that same thing, right? You got payers out there that want to come in and get a relationship with you and sell plans, and then they're going to come in and say, okay, well, we'll bring the physicians to service those individuals, but then the other 80% of the people are like, what do you do with those individuals, right? So that's a real challenge. Also, there's a QR code there, so if you got a question you want to pop in, you can, it'll pop up here, and I'll try to get that into the conversation. So, so the other thing that I heard, I think, is what role I observe this in our own communities, right? There's an education process that takes place with the local leadership team to make this shift and make this move to actually promoting a physician practice group, right, to communities. What role does physicians play in that? Do they play any role? Should they play a role? How do you guys think about that from the physician standpoint side about trying to begin to make this shift? Because it is a big shift, and you do get some pushback from your local communities about, well, this is resident choice, and now you're telling me I need to try to push a physician on to these residents. So how do you guys think about that? I don't know if one of you wants to take that, or.
Yeah, I really think that the building has to understand what we're trying to achieve, at every level, from the nursing to director of nursing to just the CNAs even, because it's a big shift in culture. And they've got to see that, and we've got to be able to prove that. And then you've got to have a provider team that's willing to have the patience and the time to really show that. I'm not going to go in the building and expect to get the whole building. I just want 3 or 4 patients. I can prove to the nursing staff. I can prove to the patients. The patients will talk amongst themselves. And it starts growing. The nursing staff say, I say I'm going to be there every week until, and we'll build this practice. I'll stop by if I just have 5 minutes. I don't have to see a patient. And I'm going to say, okay, did we do this? Did we do this? Are we going in this direction? And as it grows, people come to understand what I'm trying to achieve in the building and where we can go as a whole. And then they'll say, okay, this provider just comes in every 3 months at best. Do you want to take over his panel? Mm-hmm. And that's when we really start seeing that shift. And when the building understands that and the residents understand that, and I'm not shy to talk to people about what I do, talk to families, happy to get on the phone to see if they would like what I can provide and what our team can provide. So I think it's more you're kind of selling yourself in a way. You know, it's not as much straight primary care as because we really got to change the shift in the culture and the way of thinking. You know, I'm not here just to give meds. I'm here to prevent things from happening. You know, we're on the other side now. You know, we're on your side. We're not trying to push things. You know, a lot of patients say, Dr. Wahab, you're the pill pusher, aren't you? When they first meet me, but after they get to know me, you know, they realize what we're trying to achieve. So I think that's the big change.
One thing that might be helpful there too, just to get super tactical, because I think we're becoming friends. This is a tight, close group that we're going to get to know each other pretty well. Is doing a family night that's all for show and encouraging more resident choice is a bad idea for this type of rollout. Personal opinion alone. I've always found that you have to walk into a building. The building has to sort of nominate a awareness champion for a partnership like this, because you got to get ready to run like a full implementation on this kind of project. You know, 60 to 90 days of pushing information about this practice to your residents, to your POAs, and it may even require a call blitz, like actually picking up the phone and calling a bunch of residents and POAs and saying, hey, do you remember when you didn't get that med refilled last week? Here's a group to use that'll probably be more responsive. Do you remember when you were sent out to the hospital last month and you came back feeling worse than you left? Here's a group that you should try out. So I appreciate an approach with operators that's much more surgical, it's intentional, and it quickly ramps up the PCP group to some sort of meaningful density so that the staff in your building and the residents can start to see a meaningful difference. If you partner with a PCP group and the most residents that they ever get is 5 or 10% of occupancy in a building, your building's never going to know and see and compare a value-based PCP group with the control group. So get surgical, dedicate somebody in your building to really focus on this, get that PCP group that you've ideally selected for all the right reasons, and one of those should be that they participate in VBC programs, not just because they are the status quo in your building and have come there for years. That sounds like their convenience, not yours. But get real surgical with it, and this will pay dividends. Otherwise, you're going to linger in sort of no man's land of implementation.
One of the questions which I think is interesting and relevant, kind of ties back a little bit to what we talked a little bit about earlier, but was how do you work with plans such as Kaiser as an example, when 40% of a resident population sees them? How do you get the adoption in that situation? Or can you?
Wait, can we call on our Kaiser associate out there?
Yeah.
Oh, they didn't show up. Surprise.
Yeah. Because they don't play with anyone.
I'll take shots at Kaiser all day because I operate in Kaiser.
I don't know. Man. Woo. Oh.
Can I throw a red flag?
Go ahead.
Challenge.
In all honesty, when we implement with I operate in California, and when we launch within communities and we look at who is eligible in the building to sign up for our service, the Kaiser residents are ineligible. And we've gone to them, I think the buildings have gone to them and asked for participation in things like this. And Kaiser knows that they've got members on their product that live in these communities. They just haven't yet figured out how to come to the table or subcontract this type of service out there. And it doesn't mean you have to put in front of those residents sort of a change plan, but it does mean that you may need to introduce the topic to them that this might have been a great plan for you when you were a commercial insurance member. This might be a great plan for your group retiree product when you were living at home, but your needs are different now. Should your health plan be different too? Do you want to pick a health plan today based on the nicest hospital if that's not even the setting you want to go to? So it might just lead to some tougher conversations and probably some broker relationships so that patients can have more insurance choice that will then be able to drive optionality amongst the care teams in your building.
All right, thank you. So, and I think this is another really good question that came through, is a lot of senior living are looking at other verticals, right, as it relates to some revenue opportunities within, hospice, home health, and pharmacy and some of those things. So how does value-based care play with those own internal hospice and home health groups that an organization may have?
Yeah, so I'll take that from the Curana perspective and how we look at it. There's a reason why Curana Health we don't operate or own those verticals, because we realize it's a strategy. And I think partnering and the proper utilization of those services can really impact care and lower costs. When you look at our MSSP ACO, the biggest drivers of healthcare spend are avoidable, I'll say that again, avoidable hospitalizations. And so there's a misnomer out there that value-based care means cutting costs. I would actually challenge it's investing in putting costs in the right timeline, putting it ahead of that preventative. So actually the proper utilization of therapy and maybe that extra session is actually critical for stabilizing them and getting them to a level of care and wellness that they really need to be to prevent that bad outcome, which is ultimately going to lead to higher costs. So our strategy at Curana is to partner and utilize those services in the right mechanism. We're not the department of no. It's like, let's use it together and let's use evidence-based medicine to get a proactive approach, involve those aspects of care. And sometimes hospice, great choice. Every resident has a right to a hospice consult. We all pay into it. But maybe palliative care, they're ready for palliative care, and so we provide that solution to bridge them to hospice when they're ready and qualified. But very important about our collaboration and strategy and how we think about it from a Curana perspective.
There was a great question that was at one of the tables I buzzed around that I thought was quite different than anything we've discussed. It came from Pilar and the team's table over here. But many of the communities that you all represent and own and operate have a very IL feel to them. And a lot of these residents don't want their community to turn into a healthcare center. And so how do we start to blend primary care, value-based care into a setting that these residents are still very active, very independent, and they don't want the feel of a diluted SNF model of care that we've somewhat talked about a little bit here. And we didn't generate all the answers, but I think some that were being discussed at the table where your primary care team can do creative things that change the perception of how care is delivered from the PCP to patient relationship. Like, is that value-based PCP group using a patient portal that the patient can interact with, much like they did when they lived at home? Many value-based primary care companies do this and can do this. Many will allow IL residents to schedule themselves a self-service-like appointment. Many will ask for space in your community that they can set up a little mini clinic, so to speak, that the residents can actually come to instead of care being delivered in their home. And it almost takes the shape, and I don't want any of the physicians to throw things at me when I say this, but it's a look and feel a little bit more like concierge medicine, but the undercurrent is still value-based care, and it's still needs-based care, and it's still care at the right time for the right resident. It just can be disguised in select ways that allow the consumer, the resident, to feel as though it's still a control of their own, if that makes sense. And I'd encourage more of you to think about that too if you think that that could be a headwind.
Let me do a quick follow-up on that. So if you're an operator and you have a 120-bed independent living community, is there a place for value-based care in that community?
Absolutely.
And how, why, what are
Do you want the Bickford Allen results in your IL?
Yeah.
Probably, right? So absolutely, because again, it just means right care at the right time for your resident. Why should an IL resident be ineligible for this service? Many of these IL residents still qualify for the same value-based MA plans you'll hear about tomorrow. Many still qualify for the same ACO programs you'll hear about tomorrow. Some won't, but that's okay. They have their own options too.
There was a question that came. There is going to be a technology breakout later, but what's the technology that the question was, what's the best and most innovative piece of technology you have seen implemented or tested? And there's a lot of stuff going on. There's a lot of conversations about remote patient monitoring and all those sorts of things. So, hey, Dr. Morehouse, how does that relate to you, and how do you think about the tech side of this?
Yeah, that's a tough one. There's a lot of stuff coming out. You hear a lot about AI and predictability. I think there's a lot of companies actually in here today that are pushing their products in terms of getting the results or the data that we need to make decisions, because that's the big thing as a clinician is I need to know. I'm not seeing them all the time, but if we can predict patterns and see what's going on and that gives us ability to make choices that will have better outcomes. We use Aspire, which is our own platform, as well as we use CarePredict, and we're trying to pull all that together so we can have, because as a physician, I don't want to be flipping through a bunch of screens trying to figure out what's going on. I need one platform that I could see a list of meds. I need to see their vitals, and I need to know how many touches they've had with different providers or services to help, that patient experience, that resident experience.
When you think about technology and you think about technology solutions, do you do that through the lens of your practice and your group, or do you ever bring in what that means to an operator, right? And where's the partnership there, and how do we use that data collectively, right? How do you guys think about that when you think about technology?
I think you have to look at both, right? And saying, okay, Dr. Morris, you're absolutely right. How do I get the information in the right information, not just any information, like the right information that is actually actionable in the hands of those that can influence it, while also thinking through and partnering with our partner and saying, what technologies are you hearing and want to incorporate? What is our consumer actually wanting? Are they wanting active remote patient monitoring? Do they want passive? And then thinking about how that kind of folds into the overall care, you have to consider both, because ultimately we have our lens and we try to do the best of looking at everything, but we need our partners, and we really mean partnerships, to give us feedback, and we need to do this together. And I think that's what we're here to do.
All right. Well said. Well, thank you guys very much. Appreciate it. Really good conversation, robust conversation.